Hi, everyone. I'm Katie Carlton. I am an assistant professor of pediatrics in the Division of Neonatology at the Medical College of Wisconsin in Milwaukee, Wisconsin, in the United States. And thank you so much for this opportunity to walk you through some of my work titled Machine Learning Risk Stratification for High-Risk Infant Follow-Up. So I have no conflicts of interest to disclose. So first, let's understand artificial intelligence. Many of you may be familiar with this already, but AI is a branch of computer science that focuses on creating systems that can perform tasks typically done by humans. It includes techniques like machine learning, natural language processing, and has the potential to revolutionize industries, improve overall efficiency, productivity, and solve complex problems. And these are a few of the logos of some of my favorite AI tools. So, machine learning is a subset of artificial intelligence that performs complex decisions via pattern recognition. Machine learning algorithms and decision trees are created which optimize predictive abilities, unlike standard statistical analysis methods. It has advantages for medical prognostication and risk stratification. And machine learning algorithms for sepsis identification in the adult intensive care unit have improved patient care, safety, and efficacy and efficiency. An algorithm was embedded into the electronic medical record in the adult ICU population that actually provides real-time alerts for morbidity estimates to the clinician. And this really allowed us to bring AI to the bedside. So, how do you use machine learning? So there's a five-step process. First, you have to collect the data. You have to pre-process the data, put it into your model and train your model. Then you have to evaluate your model, and then you can deploy it into your system. So you also need to evaluate the machine learning model you've now created. And so there are four different things you're going to use to evaluate it. First, you're going to evaluate the accuracy, the specificity, the precision and recall of your model, and then determine your F1 score, which is really your balance between your precision and your recall. And artificial intelligence in neonatology is really an emerging field. We are using it to look at sepsis identification, for example, in this article, predicting bronchopulmonary dysplasia in our patients, and then overall looking at ways that we can transform neonatal care. A recent review article actually wrote that with the availability of the EMR data we have and data sharing of NICU outcomes across neonatal research networks, machine learning algorithms have shown breakthrough performance in predicting neonatal disease. So I wanted to look at using machine learning to predict developmental outcomes and inform our high-risk infant follow-up care. So we know in the United States particularly, there are 3.8 million births every year, and about 10% or one in every 10 infants requires admission and care in the neonatal ICU or the NICU. Prematurity affects over 85% of this patient population, whereas about 15% is our full term and preterm infants. When we think about adverse developmental outcomes in the NICU, prior studies have really focused on the outcomes of premature infants, or those on the left side of the diagram on my previous slide, with traditional abnormalities looking at significant intellectual disability, cerebral palsy, blindness, and deafness. And there's milder degrees of disability that are starting to be looked at now in behavior and learning disorders and are becoming increasingly recognized in children and young adults who were born preterm. So in the 1990s, the American Academy of Pediatrics highlighted the importance of high-risk infant follow-up and the developmental challenges that our preterm infants face. The AAP then expanded its follow-up recommendations for who should receive high-risk infant follow-up in 2002, including those infants born premature or less than or equal to 32 weeks, those with special health needs and dependence on medical technology, such as going home on a vent or home oxygen, or with a feeding tube, and then infants with anticipated early death, or infants at risk because of family issues. This also highlighted the importance of a multidisciplinary care model with specialists including neonatology, developmental experts, nursing, nutrition, therapies, and social workers, all with this unified goal of improving the developmental outcomes of the NICU graduates we serve. So, what does the pathway to a developmental evaluation look like for a NICU patient after discharge? So, if the patient is identified as one of those high risk patient populations by the AAP, the the patient will follow this pathway to high risk infant follow-up clinic, and then eventually, if there's concerns, they could get a neuropsychology evaluation for further diagnostic testing. But if the patient is born term or late preterm, so greater than or equal to 34 weeks, or really doesn't meet those AAP high risk criteria, they're going to rely on the developmental screening of their pediatrician or their primary care doctor. And so, despite the abundance of literature reporting that there are actually developmental outcomes that can be abnormal in patients outside of just that premature NICU population. So there is lack of data really looking at those patients who are born greater than or equal to 34 weeks. But we know that prolonged hospitalization, life-sustaining interventions that are done in the NICU render those infants vulnerable despite their term and late preterm gestational age. So our goal was to address the gap in knowledge of developmental outcomes of infants greater than or equal to 34 weeks, requiring NICU care. Because we knew that if we can identify the high-risk patients, get them into follow-up with early therapies, we can improve their developmental outcomes. So to do this, we designed a retrospective cohort study looking at infants in that gestational age range between 2013 and 2015, admitted to our level 4 NICU, and followed by a Wisconsin-based primary care provider till 6 years of age. This diagram shows our overall study design, which included a chart review process for each patient's developmental outcome, identification of significant NICU variables using univariable analysis, and then assembling 5 different machine learning models. So first, we identified the cohort and reviewed their developmental screening. So we included, again, these NICU patients who were greater than or equal to 34 weeks, and then excluded them if they didn't have any developmental evaluations between 3 and 6 years of age. And this led to the identification of 2 subcohorts, those who had received their primary care developmental screening only, and those who got their primary care developmental screening and then had gone on to complete a neuropsychology evaluation. So then we collected variables, including ones in the infant demographic category, maternal demographics, delivery course variables, and NICU management factors. And our outcome variable was there any abnormal development identified, either on their primary care developmental screening or in their completed neuropsychology evaluation? So if they had primary care developmental screening only, we considered the patient to have abnormal development if there was any concerns in the cognitive, motor, language, or social domains documented. And then the neuropsychology evaluation was considered abnormal if one or more domains scored less than the second percentile, or the patient's primary care developmental screen was abnormal. We then went on to perform our univariable analysis utilizing the 45 NICU variables of importance as the inputs for our machine learning model. And then these variables included demographics, delivery interventions, diagnoses, procedures, and discharge planning factors. We applied 5 different machine learning models in order to predict abnormal developmental screening outcomes in early childhood for those infants greater than or equal to 34 weeks cared for in our NICU. Then the 5 Machine learning models were the classification and regression tree analysis, random forest, tree net gradient boosting, multivariate adaptive regression splines, and regularized logistic regression. We then tested our machine learning model performance, and we identified their performance metrics, including sensitivity, specificity, accuracy, and precision. And we calculated the area under the receiver operator curve, which was determined for both their training and the testing cohorts of patients to assess which model was going to be our best choice in order to do both discrimination and calibration of our model. So we screened 1,355 charts of these NICU patients. We then went on to find that 87% of them received that developmental screening and did not need to be excluded. 1,106, or 93% of infants, had routine primary care developmental screening only, and 7% had both their routine primary care screening and then a neuropsychology evaluation. And overall, we found that 90% of the patients receiving a neuropsychology evaluation had an abnormal developmental outcome, whereas 44% of patients who had routine primary care screening only were abnormal. Therefore, we identified an overall 47% of infants in our cohort having abnormal developmental results. And this is important because we can compare that to the general preschool population, which has a 15% abnormal screening rate. We also assessed the current access to developmental follow-up services in the cohort of patients and found that at time of NICU discharge, 84% of infants with an abnormal developmental screen later on in childhood had not been referred to high-risk infant follow-up, and 86% were not receiving physical, occupational, or speech therapy after NICU discharge. This table shows the performance metrics for the 5 different machine learning models, and this includes the area under the curve for both the training and the testing data, specificity, sensitivity, precision, and accuracy. So let's walk through our first model, the CART model, which showed a training AUC of 0.74 with 73% specificity and 67% sensitivity. As comparison, an AUC value of zero point 0.5 indicates the inability to discriminate between a normal and an abnormal outcome, and an AUC above zero point 0.7 indicates good discrimination. Performance of the random forest, TreeNet, Mars, and regularized logistic regression models produce similar results to the CART model, but with a little bit higher AUC values based on the training cohort and specificity values, but lower sensitivity overall. This table then shows the variables of importance that were identified for each of the machine learning models out of those 45 variables that we input into each one of the models. The models identified a combination of whether or not the patient was fully orally feeding or fully PO feeding at time of NICU discharge, the number of follow-up appointments the patient went home with, the number of medications prescribed at NICU discharge, also all of variables of importance that were highlighted in the machine learning models as predictors. This diagram shows our CART decision tree model. The NICU variables included as the nodes or the branching points in the CART decision tree were full PO feeding, the number of follow-up appointments scheduled, and the number of medications prescribed at NICU discharge. We'll now walk through each part of this diagram. The first node identified infants who are discharged from the NICU not fully orally feeding as having 75% abnormal developmental screening rate, compared to those infants who were completely fed by mouth as having a 38% abnormal screening rate. You can also see that when we compare to the number of follow-up appointments at NICU discharge, if they went home not fully orally feeding and then they had 2 or more Follow-up appointments scheduled at discharge, the abnormality rate increased from that 75% up to an 84%. Now, if we look at the diagram that shows the patient was fully orally feeding at NICU discharge, if they went on to have three or more follow-up appointments, 57% had an abnormal screening rate. So this decision tree includes whether they fed or not, and then whether or not they had high appointment utilization with subspecialists at NICU discharge. The AUC of this overall CART model was 0.74 with the training cohort, with 67% sensitivity and a 73% specificity. So now the question becomes, how do we apply our results? So based on the machine learning results that we had, we proposed that the variables of importance were then integrated into our academic level 4 NICU's high-risk infant follow-up enrollment criteria. Therefore, by expanding the AAP criteria for high-risk infant follow-up to include a fifth developmentally high-risk cohort. Specifically, by expanding the AAP criteria listed here to include that fifth cohort of infants who are greater than or equal to 34 weeks, who required NICU care and did not go home orally feeding, our machine learning model would predict that 75% of those infants would go on to have an abnormal developmental screening rate in early childhood. However, we acknowledge the delicate balance between providing developmental care for all high-risk infants and having the infrastructure to do so. Therefore, by including infants not fully orally feeding, who also had two or more follow-up appointments at discharge, that would further refine the criteria to only those highest risk greater than or equal to 34-week infants from 75% abnormality rate to up to an 84% abnormality rate. So we propose this programmatic expansion, which is needed to support a growing high-risk infant follow-up population as the landscape of overall neonatal care changes in both severity and complexity. So we demonstrated that machine learning can then be used to predict early childhood developmental outcomes for infants greater than or equal to 34 weeks. And we speculate that including NICU infants greater than or equal to 34 weeks, not fully orally feeding, and with two or more follow-up appointments in high-risk infant follow-up programs will increase access to developmental services and potentially modify lifelong developmental outcomes for these patients. Thank you so much for this opportunity to present my work. These are acknowledgments of a few of my team members, and it was a wonderful opportunity to demonstrate how the future of healthcare is data-driven, and we can use AI and some of the other technology and new tools we have in order to predict patient outcomes. Thank you so much for your time, and I'm happy to take any questions.